Hello and welcome to Neurological Examination Lectures. In this lecture, we will address another part of the motor system examination, which is power assessment. There are three different ways to assess the power of the muscle. Number one, in a fully contracted muscle, the patient first completes the movement and then tries to maintain the muscle in full contraction while the examiner tries to overcome it. This method puts the muscle at maximum advantage. In a fully relaxed muscle, this is the second method. The patient is asked to contract a fully relaxed muscle as asking the patient to flex his fully outstretched elbow, and then the examiner resists the movement throughout the whole of the patient's attempt to contract it. This method puts the muscle at maximum disadvantage and may detect mild degrees of weakness. Number three, in a mid-contracted muscle, the patient is asked to partially contract the muscle as flexing his mid-flexed elbow, and the examiner resists the movement. Now that we have known the three different methods of examining muscle power, we should know that large muscles are usually tested using method 3, which puts the muscle initially at the mid-contraction position, while small muscles are preferably tested using method 1. Steady exertion, which means maintaining a steady force of resistance, is required by both the patient and the examiner throughout the test to avoid false results. Application of great force is unnecessary and may cause painful cramps in patients with hypertonia in the form of spasticity, for example. So before starting examination, the examiner should be ready to answer the following questions. What is the muscle that he is going to test, or the muscle group, and whether the limb is in the right position that maintains that only the specific muscle is going to be tested to avoid false results. What is the segmental nerve supply of that muscle, and this means the roots that are involved in innervation of that specific muscle, and which peripheral nerve supplies it. For example, the biceps muscle receives peripheral nerve supply from the musculocutaneous nerve and segmental nerve supply or root supply by the 5th, 6th, and 7th roots, cervical roots. During examination, further questions have to be addressed. Is the muscle being tested as strong as might be expected according to the patient's and the examiner's build and age? Obviously, there are different variations in the muscle power according to the age, the sex, and the build of both the patient and the examiner. Also, we have to compare corresponding muscles on both sides of the body, and we have to state the degree of weakness if we find any weakness during examination. We have also to state whether the weakness is constant or variable, and whether it improves on rest or on encouragement of the patient. We have to figure out if there are any painful conditions or any mechanical defects that may hinder the movement during examination and give the impression of a false weakness. Also, we have to ask if the actions the patient describes during history taking compatible with any apparent weakness demonstrated. If not, then we have to question if the patient is exaggerating the weakness during examination. There are 5 grades of muscle power, starting from 5, which is the normal full power, down to 1, which is the least possible muscle contraction, in addition to 0, which corresponds to total paralysis of the muscle. 5 is normal power and full muscle contraction. 4 is full normal movement of the muscle, but this movement can be overcome by resistance. 3, normal movement against gravity. So the patient can overcome gravity, but cannot overcome additional resistance. 2, normal movement when the effect of gravity is eliminated. 1 is visible or palpable flicker of contraction, but no resultant movement of the limb or the joint. The muscle groups which are routinely tested are as follows: flexors and extensors of the neck, adductors, abductors, and rotators of the shoulder, flexors and extensors of the elbow, wrist, and fingers, trunk muscles, flexors and extensors of the hip and knee, dorsiflexors and plantar flexors of the feet, flexors and extensors of the toes, particularly the great toe. As regards muscles of the head and neck, they are discussed in the cranial nerve examination section because they are supplied by cranial nerves. We start by muscles of the shoulder girdle. This figure shows examination of the deltoid muscle. The patient holds his arm abducted to 60 degrees against the examiner's resistance. The main segmental nerve supply is C5 and the peripheral nerve is the axillary nerve. Supraspinatus muscle is supplied by C5 mainly and peripheral nerve suprascapular nerve. It is tested by asking the patient to try to initiate abduction of the arm from the side of his body against resistance. Infraspinatus, which is supplied by C5 and suprascapular nerve, is tested by asking the patient to flex his elbow, hold his elbow to his side, and then attempt to turn the forearm backward against resistance. In other words, this muscle is tested by asking the patient to perform lateral rotation of the arm. The rhomboids are a group of muscles that are attached to the medial border of the scapula. They are supplied by C5 and the nerve 2 rhomboids. The patient is asked to put his hand on his waist, and then the patient tries to pull his elbow backwards against resistance. Paralysis of the rhomboids is one of the causes of winging of the scapula. Speaking of winging of the scapula, serratus anterior paralysis is the main cause of winging of the scapula. This muscle is supplied by C5, 6, and 7, and the peripheral nerve is a nerve 2, the serratus anterior, or the long thoracic nerve. It's tested by asking the patient to stretch his arms and push them against resistance, and then we observe the scapula for winging. Pectoralis major is formed of two heads, a clavicular head and a sternocostal head. It receives segmental supply from C6, 7, and 8, and peripheral nerve supply from lateral and medial pectoral nerves. Now, to examine the sternocostal head of the muscle, the patient is asked to place his hand on the hip and press inwards, and then the muscle can be seen and felt to contract. The clavicular head can be tested by asking the patient to raise his arms forwards above 90 degrees and try to adduct them together against resistance. Latissimus dorsi receives segmental supply from C6, 7, and 8, and the peripheral nerve is a nerve to latissimus dorsi, or thoracodorsal nerve. Now, there are two methods to test latissimus dorsi. The first is by palpating the muscle while asking the patient to cough, and the second is by resisting the patient's attempt to adduct the arm when it is abducted to above 90 degrees. Let's move to muscles of the elbow joint and start by the biceps brachii muscle. It receives segmental supply mainly from C5, and peripheral nerve is a musculocutaneous nerve, and obviously the patient is asked to flex his elbow against resistance, and the forearm is in the supinated position. Brachioradialis is supplied by C5 and C6 and by the radial nerve. It is examined by asking the patient while the forearm is in the mid-prone position to try to flex his forearm against resistance. Triceps muscle is supplied by C7 mainly and the radial nerve. It is tested by asking the patient to extend the elbow against resistance. Muscles of the forearm and wrist joint, we start by the extensor carpi radialis longus, which is supplied by C6 and 7 and by the radial nerve. The test is by asking the patient to hold the fingers partially extended and try to dorsiflex the wrist towards the radial side against resistance. Extensor carpi ulnaris receives innervation from C7 and the radial nerve, and it is tested in a similar way to extensor carpi radialis, but dorsiflexion is to the ulnar side in this case. Before addressing examination of the muscles of the hand, we have to know the direction of the thumb in relation to the hand during the different positions of the thumb. Abductor pollicis longus is supplied by C8 and the radial nerve. The patient attempts to maintain his thumb in abduction against the examiner's resistance. Opponent's pollicis is supplied by T1 and the median nerve. It is one of the 4 muscles in the hand that are supplied by the median nerve. The test is by asking the patient to attempt to touch the little finger with the thumb. The muscle power is preserved in ulnar nerve lesions when the rest of the hand appears very wasted. Abductor pollicis brevis is one of the other muscles that are supplied by the median nerve in the hand and by T1. To test for the power of this muscle, firstly, some object has to be placed between the thumb and the base of the forefinger to prevent full adduction, and then the patient is asked to raise the edge of the thumb vertically above the starting point against resistance. This muscle is particularly important because it is one of the earliest muscles to be affected in the carpal tunnel syndrome. Flexor pollicis longus supplied by C8 and median. Test is by trying to extend the distal phalanx of the thumb against the patient's resistance. It is wise to hold the proximal phalanx during examination. Adductor pollicis muscle is supplied by T1 and the ulnar nerve. The patient attempts to hold a piece of paper between the thumb and the palmar aspect of the forefinger. The medial 2 lumbricals are supplied by the ulnar nerve, while the lateral 2 lumbricals are supplied by the median nerve, while all the interossei are supplied by the ulnar nerves. The lumbricals are examined by asking the patient to try to flex the extended fingers at the metacarpophalangeal joints, and the interossei are examined accordingly. If we want to examine the dorsal interossei, we ask the patient to abduct the fingers against resistance as shown in the figure, while if the palmar interossei are addressed in examination, the patient is asked to hold a piece of paper between the fingers to assess the power of adduction of the fingers. The first dorsal interosseous is also supplied by the ulnar nerve and the T1, and it is examined by asking the patient to try to abduct the index against resistance. Flexor digitorum superficialis is applied by the median nerve and C8. It is tested by asking the patient to flex the fingers at the proximal interphalangeal joints. Whereas flexor digitorum profundus is tested by asking the patient to flex the terminal phalanges of the fingers against resistance. Abductor digiti minimi, which is supplied by the ulnar nerve, is tested by asking the patient to abduct the little finger against resistance. Muscles of the trunk can be divided into 3 groups. The first group is extensors of the spine. It's tested by asking the patient to lie on his face and then try to raise his shoulders off the bed. The second group is the abdominal muscles. They receive segmental supply from T5 to L1, and the peripheral nerves supplying the abdominal muscles are the intercostal, ilioinguinal, and iliohypogastric nerves. Those muscles are tested by asking the patient to lie on his back and try to raise the head against light resistance, and during this we should watch the movement of the umbilicus. The third group is the intercostals, and examination of the intercostals is rather difficult. We can just observe the movements of the ribs on expiration and inspiration and the movements of the muscles in the intercostal spaces. They are supplied by the intercostal nerves and receive segmental supply from T1 to T12. As regards the muscles of the hip girdle, we shall start by the iliopsoas, which receives segmental supply L1, 2, and 3, and peripheral nerve, the femoral nerve. The patient lies on his back and attempts to flex his thigh against resistance. Similarly, with the hip fully flexed, he resists attempts to extend it. The adductor femoris muscle is supplied by L2, 3, and 4 and the obturator nerve, and the patient is tested for the power of the adductor femoris by asking him to abduct the leg against resistance. Gluteus medius and minimus are the main abductors of the leg. They receive segmental supply from L4, 5, and S1 and peripheral nerve, superior gluteal nerve. They are tested by asking the patient to lie in his face and flex his knee and then try to abduct the hip outwards against resistance. Also, the muscle abduct the extended leg. Gluteus maximus is the main extensor of the hip, and it's supplied by L5-S1 and the inferior gluteal nerve. It's examined by asking the patient to extend his thigh against resistance. The hamstrings, which are composed of the biceps femoris, the semitendinosus and semimembranosus, they are supplied by L4-5-S1 and S2, and the peripheral nerve is a sciatic nerve. They are examined by asking the patient while lying on his face to try to flex the knee against resistance. The biceps is situated laterally while the semitendinosus is situated rather medially. Quadriceps femoris receives supply from L2, 3, and 4, and the peripheral nerve is the femoral. The patient is asked to try to extend the knee against resistance. Muscles of the lower leg and ankle. We should remember that the sciatic nerve divides into two terminal branches, a lateral popliteal branch, which is also called the common peroneal nerve, and a medial popliteal branch, which is also called the posterior tibial or simply the tibial nerve. The common peroneal nerve is further divided into two branches, a superficial branch, which is called the musculocutaneous branch, and a deep branch, which is called the deep peroneal nerve. Now, the first muscle of the leg, the tibialis anterior, receives supply from L4-5 and the anterior tibial nerve or the deep peroneal nerve. To examine this muscle, the patient is asked to dorsiflex his foot against resistance. Tibialis posterior is supplied by L5 and S1 and the medial popliteal or the tibial nerve. It is examined by asking the patient to plantar flex his foot against resistance. Then try to invert it against resistance. Peronei are supplied by the musculocutaneous branch of the common peroneal nerve and receive segmental supply from L5 and S1. To test the peronei, the patient is asked to avert the foot against resistance. Gastrocnemius is supplied by S1 and the medial popliteal nerve. The patient plantar flexes the foot against resistance. Now we move to muscles of the foot and the great toe. We start by the extensor digitorum longus, which is supplied by L5 and the anterior tibial or the deep peroneal nerve. The patient is asked to dorsiflex the toes against resistance. Flexor digitorum longus is supplied by S1 and 2 and by the medial popliteal nerve. The patient is asked to flex the terminal phalanges of the toes against resistance. Extensor hallucis longus is mainly supplied by L5 and by the anterior tibial or the deep peroneal nerve. The test is by asking the patient to dorsiflex the great toe against resistance. The last muscle is the extensor digitorum brevis. It's supplied by S1 and the anterior tibial nerve. It's tested by asking the patient to dorsiflex the great toe against resistance. Here we come to the conclusion of this presentation. Thank you very much.